Okay, hopefully I have seen you all several times by now, but we have gotten through some of our CAD, ACS, PAD, and all the other cardiac problems. We're going to talk a little bit about inflammatory and structural heart disorders. We'll start with the inflammatory disorders, and as we know, infection often causes inflammation. So when we get an infective carditis, it's like the words say, it's infective, so it has a source, normally bacterial in this case. And endocarditis, meaning it's affected the inside of the heart muscle layer. So you can see this main effect of this is on the valves, which may improve or may explain a new heart murmur or a heart murmur that's changed. So you can see on this slide here, this is the infection here, and it's affected right in the valves. This used to account for most causes were affected by rheumatoid disease, heart disease. We have done a very good job as a medical community of kind of eliminating rheumatoid heart disease, but it does still happen. But now it's less than 20% of cases, so good job for the medical community in reducing the rate of this. We've also improved the prognosis greatly just from simple things like penicillin. This can be subacute or acute. Subacute typically affects a different population and takes months. Acute affects those that have healthy heart valves. So that's really a problem, so it progresses very rapidly. Most commonly affected by strep bacteria or staph bacteria, but very rarely it can happen from a fungi or a virus. The big problem here is if we get these vegetations or the growth of the bacteria stuff can turn into an embolization and move out of the heart, and then it becomes a problem. So infective endocarditis. Oh, I missed a page, shouldn't I? No. What does it look like? This depends. It's very different. It's very non-specific manifestations. They may have fever or any of the typical things associated with infection, so it's kind of hard to pinpoint where it is. But we can see things like new or changing murmurs can lead us to look at that. The other thing is we can trick your brains right back to health assessment. You learned about splinter hemorrhages. We'll pop a picture up here real quick. Oops. Here we go. So these are splinter hemorrhages. These little tiny hemorrhages you get underneath the nail beds are kind of indicative, not diagnostic by any means, but would certainly be things that if you saw these on your patient to look into why. So what are your nursing implications? Used to be you heard about prophylactic antibiotics quite a bit. Patients that were at risk for these, it was recommended that they get antibiotics before any kind of dental procedures especially. However, there's really guidelines for that now are pretty narrow. They've done such a good job of eliminating causes and getting better at this. So now there's only certain populations where it's recommended to do prophylactic antibiotics. And we can help identify those patients that are at risk. So patients that have artificial valves, especially newly placed ones, some congenital heart defects tend to be at higher risk. But medication compliance is always still true for nursing to remember. So if they're on antibiotics for to treat this, that we need to keep them up with that. And then continuing to follow up to make sure that we cleared it. This is most often diagnosed through blood cultures. Remember, this is an infectious process, so we can look at blood cultures. They may get an echocardiogram, which is kind of an ultrasound of the heart, so we can see the infection process going on. All right, another inflammatory disease is acute pericarditis. So acute, meaning it's happening now, pericarditis, so peri, it's around the heart, and itis being inflammation. So this is an inflammation of that pericardial sac. The sac has an anchoring function for the heart, but it also provides lubrication so we don't have friction every time our heart beats. It also prevents excessive dilation. So what does this look like? Progressive pain, chest pain that's sharp, it's pleuritic. Worse with deep inspiration, worse with lying supine, And then we have what's called a pericardial friction rub. So we've got an inflammation in that sac around the heart, which means when it beats, it kind of rubs. The inside rubs against the outside. And that's kind of a hallmark of this. It's not really anything else that causes that. So if you ever are listening to heart sounds and hear this friction rub, that's an indicator of pericarditis. So what do we do? Major complications here are pericardial effusion. So this is what I was just talking about, that sac around the heart. If we get inflammation in there, the other problem is to get effusion, so a buildup of that fluid around there. Think about that now. How is the heart going to pump? If it's being squeezed by this fluid out here, we end up with what's here. It's called tamponade. So as the effusion grows, it increases the pressure inside there and starts to compress the heart. So we have to watch for that. Diagnostics, again, you'll see some ST elevation on EKG because of that pressure on the heart. And the echocardiogram is excellent at diagnosing these things, but whether it be infective endocarditis or pericarditis, usually an echo is best. Sometimes they can do cardiac CTs or cardiac MRIs, but they are more expensive tests for sure. And the echocardiogram here is very good at this as a diagnostic tool. So how do we treat it? This is very collaborative. Not much you are going to do as far as treating the pericarditis. First thing the physicians will do is to treat the underlying cause. They may need antibiotics or anti-inflammatories or antifungals, depend on what caused the inflammation to begin with. Pericardiocentesis, however, is where we take a needle and actually insert it into that pericardial sac, and they will withdraw the fluid that way. So your nursing role in this is obviously not to perform this procedure. You'll see the needle they use. This is collecting the fluid. This goes to an EKG, and this also goes on to the pressure monitor. This helps monitor, so your role here can be monitoring that monitor itself, and keeping an eye on that when he performs this procedure. But most importantly is to manage the patient's pain and anxiety. I am aware of this procedure, I know what it does, and I can still imagine being extremely anxious if a doctor was getting ready to insert a needle into the sac around my heart. So helping with that, managing the pain and anxiety, positioning, assisting the physician as you would in any other procedure, educating for your patient, monitoring for tamponade, which we actually monitor by serial blood pressures, help us see that effect. You have what's called a narrowing pulse pressure, so the number on the top goes down and the number on the bottom comes up. So those numbers start getting closer and closer together. And that's a good way to monitor for it. All right, so those are our inflammatory diseases. Now let's look at the heart valves themselves. Primarily in young people or adolescents or children, we get valve disorders from congenital problems. In adults, this is from cardiovascular disease. Adding on to everything we've talked about up to this point, we have, things that are unhealthy and causing these plaques and causing problems, and things lose their flexibility, and that's how we end up damaging the valves themselves. We're going to talk about terminology here in just a second. The most common ones in the adults are aortic stenosis, which is narrowing, or mitral regurgitation, which is the valve not functioning in its right way either. So stenosis, constriction or narrowing of that forward flow gets impeded. So if you make that valve constricted, it impedes the forward flow. Then there's regurgitation, which refers to an incompetent valve. You'll hear some physicians call it an incompetent valve. And what this does is allow the backward flow. So remember, valves are supposed to operate like a door. They open and close, let blood out, close, don't let blood out or in. So when those don't close properly, then we get this regurgitation, which allows blood to go back the way it came. Prolapse, these are where those leaflets, the edges of the valves, the flappy parts, buckle back in. This primarily occurs in the mitral valve, when we get this mitral valve prolapse. Let's look at see what those look like. So here we go. This was the vessel here, and this would be the valve. So if we are looking here at a normal valve, when it's open, and this is a normal valve when it's closed. So the open valve leaves this nice open space for blood to flow, and when it's closed, nothing gets through. Stenosed, so this means it is narrowed. So this is an open valve, and you can see this is supposed to be how much blood goes through. If it's stenosed, I'm getting much less come through. Okay. Regurgitated, so they don't close as well. So you can see here I still have an open space, so blood's still coming through. So if we look at the valves on the left side of our heart, we have mitral valves and aortic valves. Aortic going out to the aorta, the mitral valves between the atrium and ventricular. So stenosis in the mitral valve means I have problems on that side, and then aortic valves. So what do these look like? On the left side, if we damage our valves, the symptoms, regardless of which type, cause dyspnea, fatigue, increases the pulmonary artery pressure, and decreased cardiac output. These are the problems with those valves. So mitral valve problems and aortic valve problems, we end up with these symptoms. Now, on the right side of the heart, we have tricuspid and pulmonic valves. So these, again, dyspnea and fatigue, but we have increased atrial pressures, and JVD and hepatomegaly are common symptoms with these valve disorders. And again, same concept. Tricuspid stenosis means the tricuspid valve gets narrowed, and the regurgitation is allowing the backflow of blood. Okay. All right, murmurs and heart sounds. A lot of this helps with diagnosing murmurs. So the thing I emphasize here is you can't identify S3 and S4 if you don't know what the normal hearts or sounds are like. You guys are new in your assessment of real live patients besides just ones generated here in our sim labs. I can't tell you. Listen to as many heart sounds as you can all the time, every time you're in the hospital. Even if you are listening for normal heart sounds, the better you get at hearing normal heart sounds, the better you'll get at identifying abnormal heart sounds. This is another one of those slides where if you click on it and a link, the green letters here are a link. So you should be able to click on that and it'll take you to a site that has some practice sounds for you to listen, or examples of S3 and S4. Again, the best way to learn these is to do them. Okay, just do them. Practice good heart sounds. If you have a patient that you have personally, or you hear a murmur, bring in one of your fellow students and let them listen to it also. Okay, they're good sounds to get used to and listen and learn. So, diagnostic studies for all of these, for our valve problems, our inflammatory problems. Echocardiogram is a great tool for measuring valve structure, valve function, and looking at the size of our heart chambers. And we'll talk about here in a little bit why that matters. EKGs are better at heart rate, rhythm, ischemia, hypertrophy. Because remember, EKGs are talking about the electrical activity in our heart. Chest x-ray, their use in this really only is heart size, and sometimes you can see valve calcifications on chest x-ray. Cardiac catheterization, we can measure the pressure changes in pressure in a chamber. So in other words, if a valve is functioning normally, they know what the pressure should be on each side of that valve. So in a cardiac cath, we can actually check the pressure on each side. Follow that gradient across the valves as well, and they can measure the size of the valve openings as well. Obviously, cardiac cath is more invasive than an echo, EKG, or chest x-ray. So that's going to be our most invasive. So a lot of times they try to do as much diagnostics as they can without being invasive. All right, so our collaborative care here is preventing rheumatic fever and infective carditis. So our patients that are at risk for these, treating them, learning how to recognize it helps. Treatment depends on the valve that's involved and the severity of that disease. So in other words, treatment may be different for a tricuspid valve problem versus a mitral valve problem. So focus is on presenting exacerbations of heart failure, which we'll get to shortly, acute pulmonary edema, thromboembolisms, endocarditis. All these are good prevention techniques, prevention methods that we will take. So, monitoring weights and trends, assessing heart rhythm, giving meds and oxygen as needed, assessing the continuous hemodynamic monitoring. Hemodynamic monitoring consists of the blood pressure, the heart rate, the pulses, the pulse ox, all of those pieces. Careful maintaining fluid and sodium restrictions if they are prescribed for your patient. Monitoring electrolytes, and then helping your patient with conserving energy, rest, and clustering their care, just like you would do going into a patient that has isolation precautions. You kind of cluster your stuff when you go in. Do the same thing, or teach your patient how to do the same things with their ADLs. Clustering things, preserving their energy. Interventions. There are surgical interventions for valve repairs. There's less complication with repairing of valves, but they're not necessarily as effective as replacing a valve. The link here that says mitral valve replacement is actually quite involved. It's a long video of watching an actual surgical procedure of mitral valve replacement, which you do not have to watch this one. It's very medical oriented. It's just super cool to see the inside of the heart and to watch what it takes to put these valves in. They function very well and they are great. So it's a great video if you want to watch. All right, so our last one here for our inflammatory type problems is a group of diseases. Cardiomyopathy. There's lots of different types. All right. So cardiomyopathy is basically a disease process of the actual heart muscle, and there's lots of different ones. You'll look over here. This first one is showing you what a normal heart muscle looks like in these images. So dilated myopathy, look at the size of the ventricles on this side. It is dilated. Too big, which kind of sounds good, right? Let's make a bigger vessel, but it becomes very ineffective very quickly. So this is a dilated problem. Hypertrophic means overdeveloped muscle, which again may sound good, have a big strong muscle, but if you look here, you can see the size of the ventricles and atria that it causes, and that muscle becomes thick and less functional once it gets that big. So not good. All right, this can either be primary or secondary problems. So this is the problem. What could be congenital or could have some effect, or this is secondary to other problems. Dilated is the most common form. Ventricular dilation impairs the systolic function, atrial enlargement, and end up with this stasis of blood. It's not flowing back and forth. This is a big cause of heart failure. And that's what we're going to get into next. All right. Treatment, signs, and symptoms are similar to what we'll learn about heart failure, so hold that thought. Hypertrophic, asymmetric left ventricle hypertrophy without ventricular dilation. So we end up with this impaired ventricular filling. It can't fill like it should. If it can't fill like it should, then we have a problem. And this is actually the common cause. SCD here is sudden cardiac death. So in young people. So if we're doing prevention techniques for young people, they'll look for this. If we see hypertrophy in their cardiac muscles, then they're going to end up in a high risk for SCD. Restrictive was the last one on that slide back. This is least common, and this has impaired diastolic filling and stretching. So if it can't do that during diastole, then you're, again, not going to get a good pump and flow. So all of these have to do with, these are structural problems that impair the ability of our myocardium to perform its job. So if some of that's not making sense as we get into the next lecture with heart failure, a lot of this will start to make more sense. So keep this all in the back of your minds, and we will cover the heart failure part together in person.